Okay, I'm sorry, I missed the first part of the discussion. I'm really not being there with you before because of some mess with travels and so on. But thank you very much for invitation. So I will try to make some comments about the topic Dr. Kitru Panos gave me about homogeneity of data in vascular access and should data be pooled here, my disclosure. So use that Panos may use against homogeneity of data about PCB. So findings from previous RCTs and meta-analysis are mixed. If we have to put in balance the homogeneity of data and the best level of evidence, which is a combination of latest evidence, best level, of course, and published in highest ranking journal. We know that some meta-analysis significantly favor DCB over PTA, some others no significant benefits, but again, if we put in balance this, and if we look at the latest news, I would say latest RCT and meta-analysis, that one published, by heart in New England Journal of Medicine, and this last meta-analysis in European Journal of Vascular and Endovascular Surgery, no previous RCT or meta-analysis have been published in such prestigious journals, I would say. And just let's go through results, and especially the impact study and the results for the 6 months showing significantly between PCB and standard balloon for both target lesion primary patency rate and access circuit primary patency rate, which is quite interesting, and maintained through 12 months, as you can see on these slides, and also through 24 months, still off again in a paper published in New England Journal of Medicine, which is probably the highest ranking journal. And the freshest news about that, so very interesting first. The second excuse Panos may use is that there is no patient level so far that allows for subgroup analysis. And in a paper published by Panos, very fresh also, Panos suggests reviewing the data on the use of PCB for the treatment of venous access stenosis has not been conclusive. So this Guardian note would be a patient-level data meta-analysis, and I can, the has been granted because this article presents the first patient-level statistically robust and up-to-date RCT only meta-analysis covering both, and it's pooled analysis of 11 RCTs comprising more than 1,000 patients, and especially including the 2 more recent published papers, and it suggests that DCB is favored over PTA in prolonging lesion primary patency and access access circuit primary. So this is the different papers. Of course, the freshest one, including a large patient from Luchstein, and again, in terms of TLPP, it was in favor of DCB, quite homogeneous. For ACPP favors DCB, quite homogeneous again, and patients with patent target lesion. In the pooled individual patient data, the model long-term patency was 28% for DCB versus 23% for PTA, and still significant, showing that at least in this very latest meta-analysis, it's quite homogeneous. Of course, what about potential covariates for restenosis? We know that we have potentially prognostic covariates for restenosis, including a lot of things: the type of access, the location, the type or duration of the treatment, the length of lesion, and not all studies reported these parameters in this meta-analysis. Hence, the data were inadequate to perform a meta-regression. But again, no subgroup analysis does not mean heterogeneity. It just means that it was just unfeasible. The third one is there are conflicting outcomes depending on lesion type, arteriovenous type, and lesion location. Let's go back to the paper published in the impact study and about access lesion characteristics, all types of lesion in both groups, all type of lesion location, and again, through 12 months in favor of DCB by lesion type, de novo or restenotic, by EVF type, cephalic, brocephalic, brachiobasilic, over ones favors in DCB, and by lesion location, whatever the location, again, all types of location in that case, through 12 months, still favors DCB. So it's not an excuse. The fourth excuse panels may use is that the use of paclitaxel-coated balloon in vascular access is potentially associated with higher risk of mortality. Of course, you were discussing about that just before I come about the risk. We all know the potential risk published by Cat about at the SFL level with a warning letter. However, in the only EVF with 2-year results available, no mortality signal was observed by Trarotola, and there is probably, as you know, between chronic patients and hemodialysis patients in terms of survival and the importance of the maintenance of functioning vascular access for survival, which is quite important. And again, if we get back to the paper by Luke study, in terms of mortality through 12 and 24 months, no difference between DCB and PTA, showing that this is quite safe. And the last but not least is that maybe the choice of PCB device to be used is not clear. If we look at the two largest multicenter RCTs of DCBs for dysfunctional EVF, the IMPACT study and the Lutonix study, still a different through 24 months for the IMPACT study in favor of DCB, no difference for the Lutonix shown in the last meta-analysis that paclitaxel concentration matters, of course, and it suggests concentrations of paclitaxel were associated with better TLPP and ACPP. So maybe we have to use this kind of balloon for it's quite homogeneous. So in terms of take-home messages, I would say that probably a balloon is probably not equal to another balloon, that the IMPACT DCB technology is as safe as PTA and provides superior treatment effect as compared to PTA to treat any type of lesion, durable mid-term therapy as a start care for patients, for this kind of patient at high risk of repeat intervention, and that this is the freshest and highest level of evidence. Ranking journal, and again, the first robust patient level meta-analysis suggests that PCBs have better results than POBAs. In conclusion, please, panels, agree that when you look at the right papers published in the right journals and dealing with there is homogeneity of data regarding PCBs in vascular access, and there is nothing to pull anymore, in my opinion, if we look at all these data. Thank you very much.